Welcome to the bold analysis. The rushed transition from NHIF to the Social Health Authority is not going to help this country achieve universal health coverage that former President Uhuru Kenyatta envisioned if these factors are not going to be laid bare. And what the Kenya Kwanza administration tries to package as a cutting-edge solution to fix the problems at NHIF, not that much can be seen. But just before you get more into that, why did the Ministry of Health officials walk out of a press briefing that themselves they had called after sending invitations on Friday evening for media houses to converge at a city hotel? And intrigues behind a state house call to the ministry made them pull out of that press briefing. But in this podcast, I'm going to show you two critical issues why the NHIF transition to SHA is a fraud. But before that, we are talking matters health. And so I want us to take a minute, stop and take a minute and let us support. Let us discharge baby Becky from the hospital. This baby Becky here is the daughter to one of our subscribers, Ronald Kamau. And baby Becky was born with cerebral palsy. So last year in April, she had convulsions. And then she was rushed to Kenyatta Hospital, where she's been for the last 1 year and 6 months. The last 6 months, within that time, baby Becky was in ICU for 6 months. But unfortunately, when she came out, she lost eyesight. But of course, now she's under the care and she's already been discharged and is able now to be put under home-based care. But all that cannot be achieved because of a bill balance of 200,000. Ladies and gentlemen, esteemed board, I'm reaching out to you on behalf of baby Becky. I've promised the parents that next week on Monday or Tuesday, we should be able to discharge baby Becky from Kenyatta Hospital. Kindly support this initiative with any amount you can get. If you know someone who knows someone, and at the limit that you can do so that we can achieve this, 200,000 by Monday. I just believe it will be possible. As I'm talking to you, I mentioned this fundraiser early in the day, the first video that we did at 10 a.m. I've already collected 21,340. So I believe that if the more we support by Monday, we'll be able to discharge baby Becky. Her case and our story on health financing is the gist of this analysis. Let me take you through what happened on Saturday morning. Yesterday, Afya House officials sent invitations to media houses for a crucial breakfast meeting that they had organized to explain to Kenyans the new Social Health Authority, how the new Social Health Authority will be piloted on Tuesday. October 1st, the country is supposed to transition and abandon the 60-year-old health scheme known as NHIF so that they can usher in the new baby called Social Health Authority. And from the invitations that were sent on Friday evening, PS Health Harry Kimtai was to host the meeting at JW Marriott, a high-end hotel in Nairobi, Chiromo area at 7:30 a.m. flanked by the ministry in charge. He was also expected to give more details about the controversial 104 billion IT system tender that will support the health systems. I'm going to explain something on that. The breakfast meeting that was supposed to start at 7 a.m., the journalists turned up, and of course, according to the invitation that was sent last evening in that group, the journalists turned up, they were served breakfast, but they sat there waiting for hours earlier in the morning. Now, the meeting was supposed to be hosted by the PS, the ministry, the CS, SHA officials, representatives of the consortium behind the IT system. They all failed to show up. That consortium includes a company where the media has been raising questions on the ownership, and is also linked to Safaricom and the wife to David Ndii. The consortium comprises of Safaricom Limited, Apeiro Limited, and Convergence Network Solutions. The ministry, according to what they wrote, the invitation, this is what the invitation was reading. The Ministry of Health invites you to attend an update session ahead of the new health system rollout that will commence on October 1st, 2024. During the meeting, a team of experts will take the members of the Fourth Estate through what Kenyans should expect from the beginning of October and how the new system will work. The invitation, that is what was written in that invitation. I want to confirm that with what was actually in the same, that was shared in the WhatsApp. Let me just confirm. Yes, a team of experts will take the members of the Fourth Estate through what Kenyans should expect from the beginning of October. That is what was shared. However, the journalist waited there until 11 a.m. and when they contacted the communication person who was coordinating this, the CS and the PS are saying they received calls to attend a more other urgent crucial meeting, and they abstained from that press briefing. They walked out of that press briefing. All the other officials, the consortium, the IT consortium, did not show up. The other officials that had already been there walked out of the meeting, and they failed to issue that press briefing. With journalists then that were there complaining about the lack of communication from the ministry officials. If they were busy elsewhere, they're the ones that called that press briefing. Why did they walk out, and why did they just cancel early so that they don't attend? I want to show you the two controversies around SHA, why the government, Kenya Kwanza administration, is finding it difficult to address or even to issue a comment about. First, I just want to take a minute to explain. There are Kenyans who maybe are not really understanding what exactly is that transition. So, just like we had NHIF, which was a health scheme that was managed by NHIF, we also have Social Health Authority, which is an authority that is going to manage three classes of health services. Three clusters. Let me get the right word. Three clusters. And these three clusters is what I want us to understand. Now, just pay some attention and get to this part, because there is a question that Kenyans have been asking. What is the difference between SHA and the NHIF?
The message has not reached quite well. The coverage is not good. At the higher level, there's a lot of things going on in social media that may change the vision of Kenyans. They will not understand that this is for their benefit. We need you to inform them that SHA is for their benefit. They need to register so that they can access care.
NHIF was only one based on members' contribution. So members contributed a flat rate of 500 shillings. Then from that contribution, they'll be able to walk into a health service, to health center and get health services. Now, just that. Now from SHA, there are three products. There are three clusters. One is Primary Health Fund. Primary Health Fund is fully funded by government. This is where the maternity is, the level 1, level 2, and level 3. Now, this is the dispensaries. If you look at the dispensaries around you, and those health centers, community health centers, it's more dealing with curative and preventive. So, sometime last year, there were some community health promoters that were launched and they were paraded. And remember, during a ceremony, one of the holidays that was held in Kericho Green Stadium. So that is where it falls. From this is a fully funded scheme by government. According to proponents of this, the government was supposed to plug in 50 billion. Now, we are supposed to roll out this program on Tuesday, but out of the 50 billion that was rolled out, only 4 billion has been pumped in it. So government ilisema wataweka 50 billion. What they've put there is only a paltry 4 billion. So that is the first one, fully funded by government. The second one is Social Health Insurance Fund. If you ask me, this was the NHIF. This was the NHIF, but some few changes have been made in it. Those who are employed formally are going to contribute 2.7% of their income. So teachers, doctors, government officials, civil servants, anyone in formal employment is going to contribute 2.7% of his income. And then that is those ones who are in formal employment. Those who are in informal employment, boda boda, mama mboga, mtu wa kuchoma viatu, kuchoma mahindi, all those who are not in some formal employment, government is supposed to come up with a tool to know how much that household can get. So there is a means testing instruments that government is developing, or there are some cases that they are asking for personal confession, where yourself you reveal how much you earn. Then from this tool, they'll contribute 2.5% of what you get. Now that tool is not yet ready. My cue. That tool is not yet ready. And there was a question that NHIF struggled to answer. I'm not seeing either NHIF answering it. Because NHIF did not net the people from informal sector. But this one is now also targeting informal, but there is no clarity how that is going to be done. However, you will not access primary health care if you are not registered. And even you are not going to access any, so if you walk to a health center, the first thing that will be done is for you to be registered. That is why you remember sometimes they were saying that when you walk, they will try to find out what exactly they can do for you. And so there is the Emergency Chronic Critical Illnesses Fund funded by government. It was supposed to be funded in the tune of 75% to 75 billion through legislation from Parliament. Only 2 billion has been pumped there. I think you can get some explanation about this from the Citizen. And the question is about contributions and benefits. Listen to this. 500
shillings for the service. So they stopped seeing that people walikuwa wanahangaika wanateseka because this service was available. And that was just one example that I was giving. NHIF did have its issues. But why dismantle it all and start all over again? I'll give an example of what is being recommended now under SHA, what is being proposed under this new fund. I'll talk about diabetes treatment because this is a hereditary disease. My family suffers from diabetes. I have several family members who have diabetes. And we're being told under this program it's 4,300 per year for diabetes treatment, diagnosis, and that. Even
per family, right?
Per family.
That's per person.
Per person in a family.
Okay.
4,300 per person in a family.
Okay.
Let's say a father has a disease, a mother has it, maybe one of the kids has it.
Okay.
And then now there's this medication that for the injection that diabetes patients use. It's called Mixtard, and it's the one I think that is available in government hospitals and government facilities. It goes for about 500 shillings. So maybe you use one a month, okay? But then in a year you'll need about 6,000 shillings. Hiyo ni Mixtard, dawa ile unajidunga. You've not done any tests. We've not monitored you. Because diabetes is a disease that can kill because, one, you can get kidney failure. In fact, statistics tell us that diabetes you're likely to, you're 2 times more likely, you're 10 to 20 times more likely to get a kidney failure As diabetes, yes, diabetes is the leading cause of kidney failure.
Right.
You're also told that you need to go for regular checkups. You need to do scans. You need to do ECG for your heart. You need to have your eyes checked out because diabetes is a leading cause of blindness for people under the age of 65.
Yeah.
And then you're 2 to 4 times more likely to get a heart attack and a stroke because you have diabetes. And you're 20 times more likely to get amputated.
Yeah.
Not because of an accident or anything else, but because you look on diabetes. And because the high cost of all this, to avoid this, you need to have regular checkups. You need to be going to be checked. Let's check your kidneys, let's check your eyes, let's check your heart, let's check all these things. And you're saying 4,300 shillings a year for all that? I wonder, Yvonne, if there was any consultation that was done with doctors.
Yeah.
Because if there were consultations were done, they did not listen to this consultation because no doctor in his right mind would recommend 4,000 because there's something wrong here, Yvonne. And there's a question we've been asking ourselves. So you're going to make people pay 2.75% of reduction in their pay. For someone who earns 100,000 shillings, that means utamkata 2,750 shillings per month and a total of 33,000 shillings a year. And you're giving them 4,300 shillings for diabetes care. Where is the rest of the money going?
Right.
So there are all these questions. I'm just giving one instance here, diabetes, but there's also hypertension, which they put 3,000 shillings.
Per year.
Per year. Dawa peke yake.
Once per year.
Dawa peke yake. Ujaongea consultation ya daktari hapo. You're saying for glasses, 950 shillings? Okay, 900 ni frames. 50 shillings ni ya nini? Ya kulipa daktari. So let's say you need eye drops, maybe you need antibiotics, maybe you need to go back for review.
Even the lenses.
Even the lenses,
which is
kuna frames na kuna lens.
Which is yeah.
So this is one of the questions that journalists have been demanding answers. The health reporters have been demanding answers. Civil society organizations and other stakeholders are demanding answers. Was it well thought out? Benefits versus contributions. Dental, 2,000. There's some in the tune of 1,000 per household. So ukiangalia what people are contributing and the benefits from that scheme, they don't tally. The second question is about a controversial 104 billion IT system tender that has been rolled out for this transition. And the country is asking, what were we using before? How ineffective was it? Why should we make it more efficient so that we save the country from 104 billion that will be collected? Where will that money come from? And if government is looking for an investor to pump that money, how will that investor recoup back his money? Remember, this is supposed to be a health scheme to help the people. Listen to Sam Gituko's explanation in NewsGirl.
There's a name for what Safaricom is supposed to be doing. I just like to confirm so that I don't say it wrong. Well, I'll find it, but they're supposed to come up with a program that allows hospitals, that is the service providers, Social Health Authority itself, KEMSA, Nursing Council, Dentist Council, an integrated system that allows everyone else to meet, to share information, to access details about patients, and of course to also trace how the supplies are flowing. That is a pharmaceutical and non-pharmaceutical. Brilliant idea. But at a cost of 104 billion shillings to be done by Safaricom, a telecommunications company, there are questions that are being asked. Because if you look at the consortium itself between Safaricom, Apero, and Convergence, at least Safaricom is known and what they do. If you look at Apero and the shareholding that we looked at in our earlier story here, it takes you into several layers of ownership to an extent that you can't even tell who owns what. A director here has shares, but the bigger owner of that company is a holding company. This director does not have shares there, but they are just directors. I mean, it's quite convoluted to even get to understand what's going on. Again, these are companies that have been registered in July 2024. Never mind, there's an explanation that Apero had to be registered in Kenya because that's what the law says if you're a foreign company. I wonder, Smartmatic that provided election services, whether it was registered in Kenya for it to serve IBC in the last election. If you look at the law, it talks about circumstances during which you can actually go to the direct procurement. And yes, there's one of the provisions that I think the PS tried to refer to there when he said about if this is a service that has been provided by a supplier and only that supplier can now provide that service. But the example that is given, it is the kits that are given to the community health promoters.
Yes.
Were there 100,000 of them?
Yes, yes.
You want to tell me that you're going to spend 104 billion shillings on this supplier because they provided 100,000 CHP kits? CHP kits that are taken to the villages by community health promoters to go to families and check on how they are doing and also gather data.
Yeah.
So because of that provision, that's why you're going for a tender that is worth 104 billion shillings. The other question that must be asked here. So on estimate, on a good year, when everything is working perfectly, the Social Health Authority would have control of 273 billion shillings. If that rises, it could be 300 billion shillings.
So a third of that?
A third of that is going to buy a system.
Yeah.
Are you telling me the problem with the National Health Insurance Fund, NHIF, was a system, and to correct it, you need a system that cost 104 billion shillings to be paid up front by some investors, recoverable for the next 10 years?
That's what they're telling you.
Remember, to recover in 10 years, you need to take some 10 billion shillings every month.
Yeah. Mm-hmm.
Where is that money going to come from?
Yet we don't even have money for these other funds.
Exactly.
And these are the questions that the country wanted to ask, but no one was around to ask. From my assessment, the NHIF transition to SHA has been hacked by cartels that are just out to wreak fortunes. People are now looking for loopholes where and how they can roll out big tenders so that their cronies, they will use their cronies to scoop money from this scheme. And if the president and the Kenya Kwanza team, if they cannot give priority to the benefits that Kenyans who are contributing to that are going to get, myself, I've filled that form. I filled that form, and the feedback that I got is that they were not able to ascertain how much I get, so that thing seemed to have collapsed. So we are waiting. I'm going again to redo, re-edit, and see if there are other changes that can be done. But if we are going to roll out 104 billion IT system, maybe to ring fence it from what they had said as malicious claims and all that. But what was being used in NHIF, why don't it be made effective so that we can just ring fence it from bad claims? Number two, what is the value of NHIF? What was so, why did we rush from NHIF to SHA while we can't seem to see what exactly was the problem with NHIF, and if the problem was about dubious claims, where people are making claims of surgeries that have not been done. How is SHA going to prevent that? Why didn't we just prevent that? Or why didn't we just try to find mechanisms of sealing those loopholes? Then the two health clusters that have been introduced, the primary healthcare and the chronic one, they can be added and it's being managed by NHIF. The whole thing looks rushed. The deep state interest in health sector will kill that sector. And the big dream by former President Uhuru Kenyatta to achieve universal health coverage might not even see the light of the day. Thank you.